Very good afternoon, everybody. So we are going to have live discussion with OSCEs in neonatology. The first few OSCEs are going to be on statistics, and then we will have some OSCEs in core neonatology. I am Dr. Aparna. I work as Chief Neonatologist and Clinical Director Neonatology at KIMS Cuddles Hospital at Hyderabad. So we will straight away begin with the first OSCE. I hope my slides are visible. And if you have any doubts, questions, and if you want to answer to any of the questions also, please feel free to answer in the YouTube comment section. So let's begin with the first OSCE. This is going to be on statistics. So a new test. So this is about the comparison of the gold standard test versus a new analytical test. So there is a new test, which is test A, that was administered to screen for sepsis in 100 neonates at risk for sepsis. 50 of them tested positive with the test A. So let us imagine you are comparing CRP versus blood culture for the diagnosis of sepsis. So you are doing the new test, which is CRP, and 50 out of the 100 neonates that were tested positive based on CRP. However, only 40 neonates tested positive with a gold standard test, which is blood culture. So among the 100 neonates, remember only 40 were blood culture positive, which is the gold standard test for sepsis. Now, furthermore, we know that 8 out of the neonates who tested negative with test A, so let us say CRP, 8 neonates who tested CRP negative turned out to be blood culture positive. So with this information, let us now calculate the sensitivity, the specificity, positive predictive value and negative predictive value of the new test A. So in order to interpret this, we will need to first understand the concept of what we mean by a diagnostic test for any condition. So let us imagine that we have 100 patients, in this case 100 newborns with suspected sepsis. So you do not know whether these are truly septic babies or whether these are non-septic babies. We only suspect that they may be having sepsis. So what we know that is 40% of the babies have true disease, that is culture positive sepsis. So we know that among the 100 newborns, initially we saw them with the gray dots because there was uncertainty whether they are positive or negative for sepsis, we do not know. But what we eventually know is that 40% of the population has confirmed disease, that is culture positive sepsis. This is because blood culture is the gold standard test in this condition. So this is truly diseased, true positive population. So we have 40 deceased individuals and 60 non-deceased individuals. 40 newborns with sepsis, 60 newborns with no sepsis. So what is the prevalence of sepsis in this population? This is 40 by 100, which is 40%. So this figure is also going to be termed as pre-test probability. So the pre-test probability for sepsis in this population is 40% or 0.4. The probability for no sepsis is 60% or 0.6. Now, using this information and whatever we already know, when we get questions like this, try to construct the 2 by 2 table. So in the 2 by 2 table, we are going to have total of 3 columns and you will have 3 rows. So always remember, your columns are going to represent the true positives and the true negatives. And your rows are going to represent test positives and test negatives. So if you remember this, the construction of the 2 by 2 table will become easy. So again, I will repeat, the 2 by 2 table must have true positives and true negatives as columns and test positives and test negatives as rows. So let us now start by filling up the various cells in this 2 by 2 table in this example. So what we know is that there are total of 100 newborns. So we have total of 100 patients. We know that among these 100 newborns, totally 40 newborns are truly deceased, which means 40 newborns are having blood culture positive infection. So we know that the total cumulative sum of the cells in the second column is going to be 40 and the total of the number that is going to be populated in the cells in the last column is going to be 60 because this is the non-deceased population. Furthermore, we were told that 8 newborn babies who tested negative with the new test were actually having culture positive infection. So this brings the column C, which we have highlighted here, to become 8. So you populate the number 8 in this particular cell. So now let us see, we know that the sum of these two cells, that is the column of the second column, is 40. So if we have 8 in the last row, then we are going to have 40 minus 8, that is 32 in the cell labeled as A. So if we have 32 babies who were A, then we have A plus B, which is going to be equal to 50. So the column B becomes 50 minus 32, which is 18. And using this number, the last row is going to become 60 minus 18, which is 42. So if you construct the 2 by 2 table properly, wherein we have the true positives and true negatives in the two columns and the test positives and test negatives in the two rows, then you are going to get in order, the cells are going to be A, B, C, D. And we can remember these values for the various formulae. So let us first come to the concept of sensitivity. So what does sensitivity mean? So let us now imagine that we have total of 40 deceased babies, that is 40 truly septic babies, and we have 60 babies who are non-septic, that is non-deceased. Now, unfortunately, the test that we are using is not going to perfectly detect all the babies with disease. So what the test actually did was, it found that 50 total newborns tested positive for infection. So there is a total of 50% babies who tested positive with the new test A. Let us imagine they are CRP positive. But you can appreciate that there are some babies who have infection that are missed by the test A. There are also some babies who never had infection that are falsely detected as positive by the test A. Likewise, the test A comes out negative in the remaining 50 babies. But again, there are babies who some of them who did not have infection, who were not tested negative by the test A. And likewise, there were some babies who had infection or who had disease, who also were wrongly tested as negative by the test A. So what do we mean by the concept of sensitivity? So among all deceased individuals, the percentage of individuals who tested positive with the new diagnostic test is going to be represented by the term sensitivity. So let us understand that these are the four important terms. So you have true positives, that is the infected babies who are picked up as positives by the test as well. And then the remaining babies who are actually having the disease but who are falsely tested as negative by the new test are going to become false negatives. Likewise, we have true negatives, and the remaining babies who are actually non-infected or non-diseased but wrongly tested positive are going to be called as false positives. So sensitivity is nothing but test positivity divided by total deceased population. So among the entire deceased population, the percentage of babies that tested positive with a new test would give us the sensitivity. So in this particular example, the total diseased population we know is 40. 40 babies had true sepsis. Among them, 32 tested positive with the new test A. So 32 divided by 40, which is 80% or 0.8 is the sensitivity. Likewise, false negative rate, since we have spoken about sensitivity, we are going to speak about whatever is directly opposite sensitivity. So if you take the whatever is remaining, that is the test negative, which is divided by the total deceased population, this is nothing but 1 minus sensitivity, that is 0.2. So this is the same kind of box that we saw earlier. True positives, false negatives, true negatives, and false positives. Now, what is specificity? So among all the non-deceased individuals, that is non-infected babies, those who truly tested negative with the new test are going to represent the specificity. So in this example, there were totally 60 babies that were non-septic. So this represents the denominator for specificity. But Totally 42 babies actually tested test negative. So 42 divided by 60, which is 0.7, gives the specificity. Likewise, the false positivity rate is nothing but 1 minus specificity. So the remaining 18 babies that actually tested falsely positive with the test divided by the total number of non-deceased individuals, that is 60, represents 1 minus specificity. So coming back to the 2 by 2 table, so when you construct the 2 by 2 table appropriately, then you can take sensitivity as A divided by A plus C, and specificity is going to be D divided by B plus D. So remember that for both sensitivity and specificity, the denominator is the true deceased population or the truly non-deceased population. So you don't have test positives or test negatives as denominator. It is the true positives and true negatives that come as denominator for sensitivity and specificity calculation. So in this particular example, we know that 32 babies tested positive among the truly deceased population. The remaining 8 falsely tested negative. So 32 divided by 32 plus 8, that is 40, which is 80% is sensitivity. And specificity is 42 divided by 60, which is 70%. Now, what about the other two terms, positive predictive value and negative predictive value? So these two terms are relatively more easily applicable for the clinician. So when you are talking about a new diagnostic test, and when we say sensitivity and specificity, the denominator of these two terms is actually the true positives and true negatives. But as a clinician, you actually do not know which baby is truly positive and which baby is truly negative. And that is the reason you are doing a diagnostic test. So representing the utility of a test by terms like sensitivity and specificity, when one is actually not sure who is truly positive and who is truly negative itself, may lead to a lot of confusion to the clinician. So this problem is averted by having these two kind of variables, positive predictive value and negative predictive value for the test. So what do these two mean? This is very simple to remember. So positive predictive value is nothing but true positive divided by both true positive as well as test positive. So all test positives are taken in the denominator, and only the true positive, only truly deceased is taken as in the numerator. So if you take the true positives divided by test positives, it gives us the positive predictive value, and likewise true negative divided by test negative gives us the negative predictive value. So it essentially means if you have 100 babies who tested positive with the new test, how many of them actually had the disease? This is positive predictive value. Likewise, among 100 individuals who tested negative with the test, how many truly did not have the disease is given by the term negative predictive value. So again, coming to this example, there were a total of 50 test positives. The new test A tested positive in 50 individuals. The true positives were 32. So 32 divided by 50 is 0.64, which is called as positive predictive value. This is also called as post-test probability. So we saw that pre-test probability is the same as prevalence of the deceased, which was in this example 40%. Post-test probability is same as positive predictive value, which is nothing but true positives divided by the total test positives. Likewise, true negatives divided by test negatives gives us the negative predictive value. In this example, test negatives were 50, and amongst them true negatives were 42, because 8 babies that tested negative actually had culture positive or gold standard positive disease. So the remaining 42 were truly negative. So 42 divided by 50 gives us 0.84, which is the negative predictive value. So we have kind of calculated now these two terms. The positive predictive value in this example was 64% and negative predictive value was 84%. So now let us move one step further and discuss what is meant by a likelihood ratio of positive test and likelihood ratio of a negative test. So this is the last part of the example on diagnostic test utility. So these two terms are again quite useful to understand that when you get a positive test, what is the interpretation that we should have as a clinician? So likelihood ratio of a positive test basically means um, true positivity rate divided by false positivity rate. Or in other words, it is sensitivity divided by 1 minus specificity. So we already discussed sensitivity is the number of babies who are testing positive among the total number of deceased individuals. And this is to be divided by 1 minus specificity, which is false positivity rate. So in other words, you can describe this as likelihood ratio of positive test is given by the formula true positivity rate divided by false positivity rate. True positivity rate is the same as sensitivity and false positivity rate is 1 minus specificity. So in this example, sensitivity was 0.8. We saw that specificity is 0.7. Hence 1 minus specificity is 0.3. 0.8 divided by 0.3 is 2.66. So you appreciate that this sort of number, it's like a decimal number. So what it means is if you find a baby who is testing positive, the likelihood of this baby having infection versus the likelihood of the baby not having infection is 2.6 times. So the baby is 2.6 times more likely to actually have the disease rather than not have disease. Likewise, there is likelihood ratio of a negative test, which is represented by the formula false negative rate divided by true negative rate. False negative rate is same as 1 minus sensitivity. This comes to the numerator and divided by specificity, which is same as true negativity rate, comes in the denominator. So 1 minus sensitivity in this example is 0.2 and specificity in this example was 0.7. So the likelihood ratio of a negative test is 0.28. So this essentially means that an individual having kind of a negative test, a baby who is testing negative with a new test is 0.8 times, 0.2 times falsely likely to be negative rather than truly likely to be negative for the infection or for the disease. Now, finally, there is something which combines all these terms, which is called as ROC curve, which is receiver operator characteristics curve. So this ROC curve in one figure or in one look can represent the diagnostic utility of a test. So all the parameters that we discussed so far, sensitivity, specificity, the positive predictive value, negative predictive value, likelihood ratio of a positive test and likelihood ratio of a negative test, all these represent the diagnostic utility of any new test. So always the diagnostic utility of a test is compared with the gold standard test. Now, all these parameters can be kind of summarized or captured in one figure, which can be called as the ROC curve. The ROC curve stands for receiver operator characteristics curve, and area under the ROC curve represents the overall diagnostic performance of a new diagnostic test. So this ROC curve is constructed based on the x-axis, which is 1 minus specificity or false positivity rate, and the y-axis is represented by sensitivity or true positivity rate. So if at different cutoffs of the same sort of test, you can imagine that the sensitivity and specificity would be different. Say, for example, if you have different blood glucose levels for determining or for diagnosing diabetes, we know that lesser the cutoff for glucose level for detection of diabetes, the more higher is likely to be the sensitivity, whereas the lower is likely to be, the specificity is likely to be lower. Whereas if you have a high glucose kind of value as cutoff for detecting diabetes, then we are likely to miss some individual with diabetes, which means sensitivity could come down, but you're likely to have higher specificity for that cutoff because you're unlikely to detect somebody to be falsely diabetic. So you're going to have different sensitivities and specificities at different cutoffs for the same test. So now if you were to represent the various cutoffs of the test and the corresponding sensitivities here and 1 minus specificity as plotted against this particular graph, you're going to get this graph which is called as ROC curve. And the reason this curve is so important is because the total area under this curve, the total area under the ROC curve, AUROC, the greater the AUROC is, the greater is the diagnostic performance of the test. So generally, AUROC must be at least more than 0.5 for any good diagnostic test. Otherwise, the test is as useless as simply tossing a coin. The lower end of the 95% confidence intervals limit of the AUROC must be more than 0.5. And when comparing different tests, you can use the AUROC as one simple test or one simple variable for comparing the diagnostic performance of different tests. So far we have discussed sensitivity. Sensitivity is given by the calculation A by A plus C, if you remember from the 2 by 2 table. So it represents in the denominator the total true positivity, and the numerator you have the test positives. So among the total deceased population, how many tested positive is represented by sensitivity. Likewise, among all the non-deceased or healthy population, how many tested negative in the new test is given by the term specificity. And then we introduce two other terms, the positive predictive value and negative predictive value. Remember that the denominator of these two parameters is the true positives and the true negatives. So sorry, is the denominator is the test positives and the test negatives. So PPV or positive predictive value means among those who tested positive, how many were truly deceased? And this is also called as post-test probability. And the negative predictive value means among those who tested negative for the new test, how many were truly negative. So these were the different first four terms that we learned. Then we discussed likelihood ratio of a positive test and likelihood ratio of the negative test. So in simple terms, likelihood ratio of positive test means true positivity rate divided by false positivity rate. Then finally, we looked at the ROC curve. The ROC curve is a curve that represents the overall diagnostic performance of any new diagnostic test. The x-axis is represented by false positivity rate or 1 minus specificity, and the y-axis is represented by sensitivity or true positivity rate. So let's now move on to the next question. We're going to have 5 questions on statistics, and then we'll discuss some core neonatology questions. The next question is going to be something about understanding what are the different types of variables in statistics. So you have something called numerical variable. You have something called as a categorical variable. Again, we have different types of variables within these two broad terms. So let us take up some examples. So I'm going to give what type of variable it is. So let's take the example of heart rate. So what kind of a variable would it be? Is it a numerical or a categorical variable? Those of you who want to answer are free to answer in the YouTube chat box. So heart rate obviously is a numerical variable, right? Heart rate is going to be a numerical variable. But what type of numerical variable is it? Is it a discrete numerical variable or a continuous numerical variable? So let us discuss these things with examples. Then we have some more examples. Apgar scores. Then we have temperature. Let's take another example. The nationality of the patient, height of the patient, hemoglobin, and stages of disease. So let's not confuse ourselves. I'll give some explanation and then we will revisit this example. So there are different types of variables as we discussed. So we have nominal, ordinal, interval, and ratio scale. So now nominal variable obviously is a variable that only has a name. So for example, country. You can either have India, Pakistan, or United States of America. It doesn't have any value. Doesn't have any particular order or particular superiority. The next type is ordinal variable. Ordinal variable is also not a number. It is also something like a category, but there is a certain order. For example, let us say stages of a tumor, stages of disease. So I can have a column in my study where I just have to record the stage of BPD or stage of necrotizing enterocolitis. So I'm going to have entries like stage 1A, 1B, 2A, 2B, etc. Now, these are not meaningful numbers, but still they have a certain order. You know that stage 2A is obviously more severe than stage 1B. Likewise, stage 3A may be more severe than stage 2B, or 3B may be more severe than 3A. So when you have names with a certain order which kind of says a sequence of least value to the highest value, then you're going to call this variable as an ordinal variable. Now furthermore, if you have a numerical data wherein there is equal interval between the various numbers, then this is called as interval scale. And furthermore, if you have more meaningful 0 point, it is called as a ratio scale. So the last two, interval and ratio scale, they are generally going to be sort of a numerical data, and the first two are likely to be categorical data. Now, why this is important for us to understand is because we are going to use different statistical terms to describe the means and to compare these types of variables in different groups. So let me give an example of ordinal variable and ratio variable. So when you have numerical data where there is equal interval between the numerical variable, but there may not be a very meaningful 0 point. So for example, if you have temperature represented as Celsius scale. So here, 36.5 may represent a normal temperature, whereas if somebody has a temperature of 37.5, you know that the temperature is 1 degree Celsius higher. But again, we do not have a meaningful 0 point here. So there is nothing like a 0 degrees Celsius that is actually clinically relevant. Whereas if you represent same temperature in Kelvin scale, we have a meaningful 0 degrees as a value for temperature. So this becomes a ratio scale. So the last two parameters, if they are going to be normally distributed in a certain group, which means they have equal number of patients lesser than the average and equal number of patients greater than the average. If you represent all the values in the group, it's going to look like a bell-shaped curve. This particular data in two groups can be compared using tests called as parametric tests, like t-test. Whereas all other variables, that is a nominal and the ordinal variable, these are going to be compared using non-parametric tests. Likewise, if the interval and the ratio scale variables are again not normally distributed in the certain group of patients, and if they have skewed distribution, that is, say more a number of patients tended to have lower values in a certain parameter. For example, if most of your population had weight which was lesser than the mean weight for some reason, most of the population is malnourished, but you have very few patients, like very small number of patients who have higher weights. So this is going to be called as a skewed distribution. This is non-normally distributed data. So if it's non-normally distributed interval and ratio variable and any kind of nominal and ordinal variable, we are going to use tests called as non-parametric tests to compare them in different groups. So let us again look at the examples we took. Now, heart rate is obviously a numerical variable. This is going to be a number. You cannot have a decimal point for this number. So, heart rate can be either 145 or 155, or you may have 120, 100, but you're not going to have a decimal point. Now, what about Apgar score? Now, Apgar score, you're going to have score like Apgar score of 5 or 6 or 7. Now, this is a classical example of ordinal data. So, although this looks like a number, now what we know is an Apgar of 4 is not necessarily twice of Apgar of 2. It is just a number to represent the severity of the baby's depression at the time of birth. So, this is more like a count data, but there is a certain order. We do know that Apgar of 2 is lower than Apgar of 4. So a baby who is born with an Apgar of 2 was more depressed than a baby who was born with an Apgar score of 4. However, it doesn't mean that a baby with Apgar score of 2 was half as active as a baby with an Apgar score of 4. You cannot interpret it that way. So the meaning, the number doesn't have a direct kind of clinical correlation. However, the order of these numbers is definitely meaningful. Now, temperature is a numerical variable. Again, temperature, if you're representing in the Celsius scale, it would classify as an interval variable, whereas if you take it in Kelvin scale, it will classify as ratio scale. Nationality, again, this is going to be a simple name. This is nominal data. So this is going to be compared using non-parametric tests. Height of participants is clearly a numerical data. So this is one parameter where you can have decimal points. Hemoglobin is again numerical. Stages of disease, again, similar to Apgar score, is going to be a ordinal data. So you can notice that in the numerical data, some of them have they are going to be continuous numbers and some will be discrete numbers. For example, if you had one numerical data that represents the number of fingers or say the number of lesions, the number of skin lesions that the baby has. So you may have a study where you're counting the number of pustules that the baby has on the skin. So you cannot have a decimal point in this particular data. So you cannot have 5.5 pustules. So you either have 5 or 4 or 6. So this kind of numerical data where you can't have decimal point is called as discrete numerical data. Whereas if you have numerical data which can be expressed as decimal points meaningfully, then this is called as continuous data. For example, the mean height of participants, the mean birth weight of babies, or the mean hemoglobin of babies that are admitted in the NICU. So you can very rightfully have a hemoglobin of 8.5 grams. That is possible. But you cannot have 5.5 pustules. So a numerical data that can be expressed as decimals is called as continuous numerical data. Something that can't be expressed as decimals would be called as discrete numerical data. Now, why are we dividing the variables into different categories? It is because we want to understand the tests that are going to be used for comparing these data among different groups. So if the variable that is being compared among two groups is going to be nominal, for example, you are doing a study where you are comparing the effect of a certain intervention, say using probiotics to study the effect on necrotizing enterocolitis. So you have a group of babies who have received probiotics, another group of babies, control babies who did not receive probiotics. So you're going to list down all the different variables in the different groups. So you start with something like the mother's educational status. So this is going to be simply a numerical data. So you may say school educated or undergraduate education received, mothers who had got postgraduate education. So you may classify this. So this is going to be a nominal data. Now, if there is nominal data in two groups, then if the 2 by 2 table where all the cell size is expected to be more than 5, then we use something called as a chi-square test to compare this variable in the different groups. And if you expect the total size of the variable, the number to be less than 5, then this is going to be compared using Fisher's exact test. On the other hand, if you had skewed data in either category or ordinal data, is that is in either of the two groups, if the distribution is going to be skewed, then we are going to use something called as a Mann-Whitney U test. Whereas if the variable is being normally distributed in both the groups, then we are going to use a student's t-test. So this is classical for numerical variables. So if, for example, you are comparing the birth weight of the babies in randomized to these two groups, randomized to the probiotic group and to the control group. So what are we going to find? Either they are going to be normally distributed or they can be skewed distribution of the birth weights. So if in both the groups, the numerical data has normal distribution, that is the distribution looks like a bell-shaped curve, then we can use something called as a student's t-test to compare the two groups. On the other hand, if we have more than two independent groups for comparison in a certain study, say for example, you may have three groups that you are comparing. Like the example being, you did a study to compare a pulse oximeter number called perfusion index in three groups of babies. One, a group of babies with a very large PDA. Two, group of babies with a small PDA. And three, group of babies with no PDA, patent ductus arteriosus. So if you had three such groups for comparison, again, let us see how we are going to compare different variables in these three groups. So if you had nominal data, like data that is represented as a name, for three groups also, we are going to still use chi-square test. On the other hand, if you had skewed distribution of numerical data or ordinal data, then we will be using Kruskal-Wallis test. And if there is normally distributed data in all the independent groups, then we are going to use a test called ANOVA or analysis of variance. So we've discussed in this OSCE about the different types of variables. So you broadly have numerical variables and categorical variables. Numerical means variables that can be represented as numbers. Numerical variables can again be discrete or continuous, whether they do not have a decimal point meaningfully or they can be represented with a decimal point meaningfully. On the other hand, if you have categorical variables, we generally use nominal or ordinal. Nominal is just like a name. Ordinal is something that has an order or a sequence from lowest to highest or highest to lowest. We can again have interval or ratio scale also in the numerical variables. Now, overall, this understanding of what type of variable we are dealing with helps us to decide the test that we are going to use for comparison of these variables among different groups. So just remember that if you have two groups and if you have normally distributed data, then we are going to use student's t-test. Two groups, if the data is skewed or non-normally distributed or ordinal type of data, then we use Mann-Whitney's U-test. More than three groups and normally distributed data in all the three groups, then we are going to use ANOVA. More than two groups and skewed distribution in all the groups or at least one of the groups, then we'll be using Kruskal-Wallis test. And if it's nominal in all the three groups also, you can use chi-square test. Now let's move on to the next OSCE. I'm going to give you some examples and you can identify the test that you're going to use for comparison of these variables in different groups. Please try to answer in the chat box if possible. Okay. So let's begin. So what is the test that will be useful for comparison in the following studies? Weight gain over the first 10 days after birth. This is compared among mothers, expressed milk-fed group, donor milk-fed babies, and formula-fed babies. So how many groups do you have? You have three groups. Babies who are EBM-fed, donor milk-fed, and formula-fed. And the variable that you're going to compare is the weight gain in grams per kg per day. So you're going to use ANOVA, assuming that this is normally distributed because you have three groups. With what test would you compare the birth weight and weight at 10 days after birth in one group of preterm babies? So birth weight and weight at 10 days. Now the important thing to note here is this the same baby that you're taking? Yes, for the same baby, we're going to check the birth weight as well as weight at 10 days. And how many groups do we have? We just have one group of preterm infants. And each of these infants, we're going to check the birth weight and the weight at 10 days. So here, we are going to use a test called as paired t-test. Why do we use paired test? Because both these parameters are measured from the same baby. Next, a study is being performed to test an intervention that occurs prenatally to improve neonatal transition right after delivery. The main outcome variable is Apgar score at 5 minutes. So you're going to compare Apgar score at 5 minutes in those who received that intervention and those who did not receive the intervention. So you're going to have two groups. And what kind of variable is Apgar score? We discussed that it's an ordinal variable. So you're going to use the Mann-Whitney test because this is a non-parametric test. Next, a study of the impact of type of feeds and presence or absence of NEC compares the proportion of disease, that is NEC in one group, human milk feeds versus another group, formula feeds. So you have two groups and the variable that you're going to compare is the presence or absence of NEC. So presence or absence of NEC is just a nominal variable. So this is going to be expressed as a proportion in each of these groups and the test that you're going to use is chi-square test. Birth weight is compared with weight at day 10, day 20, day 30 and day 40 after birth and weight at discharge among breastfed babies, donor milk-fed babies, formula-fed babies. So how many groups do we have now? Three groups: breastfed, donor milk-fed, formula-fed babies. And we're going to compare birth weight as well as weight at day 10, day 20, day 30 and day 40. So this is a very kind of unique test that we use, a kind of statistical analysis called repeated measures ANOVA if we have to compare this particular variable in these three groups. So I hope it's clear so far and we'll move on to the next two questions. These are also on statistics. So what do you mean by type 1 error and type 2 error? We often keep hearing these two terms, type 1 error and type 2 error in statistics. So type 1 error, which is generally considered to be a more serious type of error, is the rejection of the null hypothesis when it is actually true in the population. So what does null hypothesis mean? So when let's imagine you are doing a study comparing an intervention versus control. Now, null hypothesis essentially means that there is no difference between the two groups, which means there is no difference between the intervention and no intervention. So if you ended up rejecting the null hypothesis when the null hypothesis is actually true, it's called as type 1 error. So this is actually finding a difference or finding a statistically significant difference in the outcome when the reality is that the intervention did not produce any significant effect on the outcome. So this is generally taken to be a more serious type of bias because you're actually kind of over detecting a difference which is not really existent. So this is a classical example, type 1 error. So wherein a doctor is, telling a man that he's pregnant. So this is actually not possible. And the type 2 error, which is also called false negative interpretation, is telling an obviously pregnant woman that she is not pregnant. Type 2 error is still a relatively acceptable error in statistical terms because, if in your study you did not find the difference because of the intervention, then it is likely that in a subsequent study that it may still be, picked up if that was adequately powered study. But type 1 error is way far more dangerous because we may end up believing that a useless intervention is potentially very useful and beneficial, and this may result in a lot of overusage of this intervention. So this is a tabular representation of the null hypothesis of the type 1 and type 2 error. So when you end up rejecting the null hypothesis, then when it is actually true, then this is called as type 1 error, which is lower down here. This is also called as the alpha error. And type 2 error is when we accept the null hypothesis to be true, when the alternate is true. So when you end up rejecting that the intervention had any significant difference when the truth was that the intervention was truly beneficial. So this is called as type 2 error. Now the next OSCE is a randomized control study was performed to evaluate the effect of probiotics on incidence of NEC. The following is the primary outcome. So you can see that the primary outcome is necrotizing enterocolitis, that is disease. We have two groups of individuals. Again, when we have calculations for relative risk and NNT, remember that you have the truly deceased and the non-deceased groups as the columns. So you have the interventions here on the rows, probiotics and placebo. So the incidence of NEC in the probiotic arm was 1 divided by 50. So there was one baby who developed NEC and 49 with no NEC. Whereas in the placebo group, you had 5 with NEC and 45 with no NEC. So the incidence of NEC in the probiotic group was 1 by 50. And the incidence of NEC in the placebo group was 5 by 50. So what is the relative risk, absolute risk reduction, and NNT? That is the question. Now, relative risk is represented by the incidence of disease in the exposed divided by incidence of the disease in the non-exposed. What is the disease here? Necrotizing enterocolitis. And what is the kind of exposed group here? That is the group that is receiving probiotic. So the relative risk is A by A plus B divided by C by C plus D. So it is 1 by 1 plus 49, that is 50, divided by 5 by 5 plus 45, which is again 50. So eventually it will become 1 by 5, which is 0.2. So the relative risk of developing necrotizing enterocolitis in the probiotic exposed infants is 0.22 of the risk of developing NEC in the non-exposed infants. So it essentially means that the risk of developing the disease is in probiotic exposed infants is 20% of the risk in the control infants. On the other hand, the absolute risk reduction represents not the ratio, but the difference in the risk of developing disease in the exposed and the risk of developing disease in the non-exposed infants. So the absolute risk reduction in this scenario is given by the formula A by A plus B minus C by C plus D. So this is the same as 1 by 50 minus 5 by 50. So here it will become minus 4 by 50, which is minus 0.80. Nevertheless, this can be positive or negative. It still is the absolute risk reduction. Now, NNT, which is the most important statistic for governance and policymakers, is the number needed to treat for significant benefit to be achieved for at least one baby. So this is given by the formula 1 divided by ARR, 1 divided by absolute risk reduction, which is 0.08. So because absolute risk reduction is represented as a percentage, it will become 0.08. Now, this is equal to 12.5, or when rounded up 13 infants. So what it essentially means is you may have to actually treat 13 infants in order to prevent NEC in one infant is what it means. So I'll stop with this OSCE for the day. So we'll discuss briefly about some community parameters like NMR, early NMR and IMR in India as per SRS. This is as per 2013, but you have more recent data from NFHS 5, which is National Family Health Survey. We must know which are the states which have the least and the maximum NMR and what is the commonest cause of neonatal mortality rate. So one important thing is to remember that the neonatal mortality today contributes to almost 60% of overall child mortality. And NMR can be further classified as early and late NMR. Early represents the death within the first 1 week, which is 0 to 6 days, and late is 7 to 28 days. So the numbers are 28, 22, and 40 per thousand live births. The current NMR has further come down to around 22 per thousand live births. The states that have the most and the least NMR in India are Odisha, which has the maximum neonatal mortality rate, and Kerala, which has the least. And the most common cause of death is prematurity. So this gives a state-wise representation of NMR. Of course, this is not very recent. This is from 2013, nearly 10 years old. Kerala's NMR is 6, and this is a further slightly dropped perhaps to around 5, and this remains the lowest NMR across the country. And the state with the maximum NMR is Odisha, which has 37 per thousand. This is as of 2013. I would request all of you to kindly look into the latest data from NFHS 5 as well. Now, the common causes of neonatal deaths are prematurity, which is the contributor for the maximum newborn mortality, followed by sepsis, which cumulatively accounts for 21% deaths, and asphyxia, which is also called by the term intrapartum related deaths, which is 19.2%. Okay, these are some important national programs for all of you to remember. So we have the oldest to the newest listed here from bottom to top. You all would have heard of the Janani Suraksha Yojana, NSSK program. So Navajot Shishu Suraksha Karikram, which was launched in 2019. So the NSSK aimed at zero out-of-pocket expenditure for maternal health implemented in all states and union territories. So this meant that families could avail obstetric service at zero out-of-pocket expenditure if they were below the poverty line. Then came the FBNC, which is facility-based newborn care. So then you had so facility-based care actually had divided the newborn care facilities into various levels like newborn care corners, newborn stabilization units, and then SNCUs were also established. And then Janani Suraksha, Shishu Suraksha Karyakram, which came up in 2011, started providing basic newborn and health resuscitation training. And later on, the RBSK program came in, which dealt with birth defects, diseases, deficiencies, and developmental delays, including disabilities. So this is a very popular curve, which is called as a forest plot. You might have seen this plot if you open any of the Cochrane systematic reviews. These are all available from the Cochrane library. So this is a plot that is used for representing the cumulative effect of an intervention on a certain outcome. And this information is derived from various randomized controlled trials that have compared the effect of the intervention in the test group versus the control group. So this particular forest plot that we are seeing here looks at the meta-analysis of the effect of therapeutic hypothermia versus normothermia or maintaining normal temperature in newborns with perinatal asphyxia with the outcome of death. So you can see that in each of these studies, the events and the total number of patients has been given in the various columns. And you also have a column that shows weight in percentage. So this represents the weight or the importance of this particular study for the whole meta-analysis. And in each of the study, we have a risk ratio or a relative risk for the outcome. For the first study, for instance, it is 0.86, and you have the 95% confidence intervals of this particular study represented in the brackets. So what this means is, in this particular study, the relative risk for developing the outcome among the exposed versus the incidence of outcome among the non-exposed was 0.86. And the variability of this relative risk could vary between 0.68 to 1.07, and that is represented in this forest plot for each of the individual studies. At the end, you have something called as the pooled relative risk, which is represented by a diamond. The center of the diamond represents the pooled or the point estimate of this relative risk, and the ends of the diamond represent the 95% confidence intervals of this relative risk. So if the pooled relative risk stays to the left side of the line of equivalence entirely, so including the ends of the diamond, then it represents that this intervention has a statistically significant effect on the outcome of interest. So in this particular example, the outcome of interest is mortality. So therapeutic hypothermia significantly reduces mortality in cooled infants versus the non-cooled infants is what this pooled relative risk means. And how much reduction it can achieve is represented by the exact point estimate. So here the point estimate of the RR, the pooled RR is 0.76. So RR or relative risk of 0.76 means that there is 24% reduction in the occurrence of the outcome with the intervention versus without the intervention. And this variation, this relative risk can vary between 0.69 to 0.84%. So again, the reduction in the outcome can vary between 31% to 16% reduction in the outcome. There are some other important things that you can note here. So these are shown in the circle. The first circle is the point estimates of the first two are randomized controlled trials. Then we have the diamond that represents the overall pooled estimate or the pooled relative risk. And the I-square that is represented here in the lower end of the forest plot is nothing but a measure of heterogeneity amongst the different studies. So how similar or how different were these studies? That is represented by the parameter called I-square, which is the measure of heterogeneity. So why this is important is we should be careful that we don't combine very heterogeneous studies or very heterogeneous populations. So if you end up combining a group of apples and oranges and grapes, and then you try to make an interpretation from the whole population, we may be actually making some interpretation which is not relevant to these populations individually. So if you have very high heterogeneity in the population or high heterogeneity can either be in the population or in the intervention tested or in the co-interventions or the type of measurement used for outcome in any of these places. So when heterogeneity is very high, it reduces the confidence on the total inference of the forest plot. And then we may also have to use something called as the random effects model in preference to the fixed effects model if heterogeneity is very high. So I think I'll stop here for the day, and we can take up any questions if there are any, and we will discuss the rest of the OSCEs in the upcoming sessions. So if any of you have questions, I don't know if you can post them in the comment box. You're free to post any questions if you have any. Okay. If not, I presume most of you might see the recorded version of the video. So please feel free to reach out to the organizers if you have any questions or comments and doubts.